Next up, we've got Dr. Sufyan, and he'll talk about the tibial tubercle osteotomy with MPFL reconstruction. Over to you, sir.
Thank you very much for the opportunity. Been a great meeting lately. Importance of osteotomy, and I think the statement is very clear and loud that you need to work around your knee. You need to know your osteotomies. You need to know your rotational angles before you actually offer your patients a successful management to keep them in that matter. So my job is to talk about tibial tubercle osteotomy along with an MPFL reconstruction. Now, when we talk about patellofemoral instability, it's a highly complex condition, and you need to know your anatomy of the PFJ and the biomechanical implementations around the knee joint, and actually when you're in the actual benefits of the theoretical benefits of combined procedure when you actually are offering the patient to have a stable sort of a patella. So what is the definition of PFI? It's an asymptomatic deficiency of the constraint by the soft tissue tethers, the chondral bony geometry, the muscular forces which actually lets the patella from its asymptomatic position and with respect to the femoral trochlea, and it is due to balance in this, the bones tends to stay, the balls tends to stay inside the socket in the different ranges of motion. So what are you looking at? In patholaxity, you're looking at the medial structures, especially the MPFL structures, the trochlear dysplasia, the famous classification system by Dijor, which has revolutionized the understanding of a patellar instability, the TT-TG distances that needs to be measured before every treatment being offered, the patella alta condition in which leads to the failure of your reconstruction and your limb alignment. So why to treat with them, why to deal with them? Because if you leave these things, leave this dislocation, it leads to cartilage injury, patellofemoral degeneration, and quadriceps atrophy. So the surgery that we like to offer them should be a balance between a soft tissue and a bony procedure. Now, after 2012, the algorithm has been straight that you need to strengthen the medial structures by using an MPFL, and the roles of the lateral release isolatedly of hemoplasty has been less discouraged in all cases, and the MPFL has to be isolated or in combined. Well, pathology does not read the book. And because of these reasons, the knee surgeries which has been around the knee are the medial MPFL reconstruction, the tibial tubercle osteotomy, and the trochleoplasty. In difficult cases, you need to go and combine either of these surgeries to actually get your patella balance into the trochlea. So what are the indications for MPFL with TTO? You're looking at recurrent patella dislocation with TG distance more than 20 mm, and especially the patella alta. And you need to tend to stay away from patients of younger age who with open physis and who has actually developed an arthritis. So looking at the algorithm, if you've got a patella alta situation and your TT-TG is greater than 20 mm, then you need to go and offer them a combined sort of a procedure, a TTO along with an MPFL. And MPFL, as we all know, that's the primary constraint. It provides 60% of the resistance forces against the lateral structures. And MPFL in isolation can be a good procedure, but for what condition? If you're looking at Dijor A and Dijor B. And in those conditions, you can go take a graft, move around the patella in whatever best possible way, fix it to the shuttle point, and then you can get away with that. But in studies, it shows that if you're going higher in your Dijor, like to a Dijor C or D or raised TT-TG distance, then you need to combine it with an osteotomy. And looking at historical perspective, Fulkerson tried to move the osteotomy anteriorly, then medially, then the sliding one, and till date, the sliding one actually provides to be a good sort of an option in which the distalization of the patella brings it back down and by calculating your insult-Salvati ratio, and this condition, and it should be done prior to your MPFL reconstruction, so that once you have actually kept the patella onto the medial side, and then you go and do the osteotomy first, and after that do your ligament reconstruction and stabilize your medial structures if it's in traumatic. Now, in this, there are also issues which have been regarding that. There in consensus, there is no certain value that have actually been advised, and a recent joint consensus guidelines needs to be look into whether to actually go into, and it says that TTTG times fails into consideration the tibio femoral rotation, and now people have started using the TTPCL distances that has been there in various sort of studies. Now, this was a study which was done at my unit, in which we actually look at 48 patients, followed them up for 5 years with TJOR A and B, excellent outcomes, no sort of dislocations. And this is one of the paper that I had no clue that Mr. Ijaz Mughal is also one of the authors in this paper, in which they also suggested that if you go higher into your DJOR classification, a C or D, with a trochlear dysplasia, if you're combining an MPFL along with a TTT, along with a tibial tubercle osteotomy, gives you a very good results in actually stabilizing it. And at times that it's a point that needs to be agreed that in terms of fine tuning, you need to also do an osteotomy of the distal femur to actually balance your knee joint and to give them a proper sort of a stable sort of knee that can be followed up in the due course of time. So thank you very much. That this was a little bit brief sort of my overview of actually stabilizing your patella into the joint, and the importance of actually combining your osteotomies along with your soft tissue reconstructions. Thank you. Thank you very much.